What do you know about the NHS values? How do they align with your own values?
The NHS values, particularly the 6 Cs, serve as the ultimate blueprint for clinical excellence. They bridge the gap between technical skill and genuine humanity. Here is how they align directly with my practice. Care is delivering the right treatment safely, while compassion is how it feels to the patient. In a high-stakes surgical environment, patients feel incredibly vulnerable. For me, compassion means sitting at eye level with a terrified preoperative patient, actively listening to their fears, and treating them with absolute dignity. It is about treating the person, not just the surgical site. Competence is non-negotiable in the operating theater. It means maintaining flawless clinical knowledge, mastering advanced surgical technology, and strictly enforcing infection control. However, competence fails without communication. I utilize clear, structured communication tools like SBAR during critical post-operative handovers to ensure zero details are missed when transferring a patient to recovery. Courage is having the professional bravery to speak up for patient safety. It means calling a timeout to halt a fast-moving surgical line if I spot a sterility breach or a missing surgical count, regardless of who is in the room. This stems from a deep commitment to our profession and our patients, ensuring I consistently deliver the highest standard of care, even on the most exhausting 12-hour shifts. I chose a career in nursing because my personal ethics mirror these exact values. I believe that clinical excellence is not just about executing technical tasks flawlessly, but about upholding a culture of safety, advocacy, and deep empathy for every individual under our care.
What do you understand about the role of a Band 5 staff nurse?
The role of a Band 5 staff nurse is the clinical backbone of the ward, requiring a balance of direct patient care, clinical judgment, and team coordination. At this level, a nurse is fully accountable for assessing, planning, implementing, and evaluating patient care plans in accordance with evidence-based guidelines. The core responsibility involves managing a specific caseload of patients safely, administering medications accurately, and recognizing early signs of clinical deterioration. It is also a role centered on effective collaboration within a multidisciplinary team, ensuring seamless communication between doctors, therapists, and families. Furthermore, a Band 5 nurse acts as a vital patient advocate, ensuring safety protocols like the WHO surgical safety checklist are strictly maintained. Beyond clinical tasks, the role demands strong leadership skills, such as supervising healthcare assistants and mentoring student nurses during shifts. It requires a commitment to continuous professional development, clinical governance, and maintaining the highest standards of the NMC code. Ultimately, being a Band 5 nurse means delivering compassionate, high-quality care while maintaining operational safety and efficiency on the front line of the healthcare service.
Can you describe a time when you managed a deteriorating patient? What did you do, and how did you escalate your concerns?
During a night shift last month, I was monitoring a 50-year-old male patient who was 6 hours post-op from a major abdominal resection. His initial recovery had been stable, but during my routine hourly rounds, I noticed a sudden shift in his vital signs. His heart rate had spiked from 80 to 120 beats per minute, and his blood pressure had dropped to 90/60. The primary challenge was diagnosing the root cause rapidly while preventing him from slipping into severe hypovolemic shock. I immediately calculated his national early warning score, which came out to a critical 6. I knew I had to escalate this situation without causing panic on the quiet ward. I immediately used the structured SBAR tool to call the on-call surgical registrar. I clearly communicated the situation, background, my assessment of potential internal bleeding, and a recommendation for an immediate review. While waiting 4 minutes for the registrar to arrive, I took immediate clinical action. I administered high-flow oxygen via a non-rebreather mask, established a second wide-bore intravenous line, and started a rapid infusion of 500 milliliters of normal saline as per our emergency protocols. I also drew urgent blood samples, including a cross-match and venous blood gas. When the medical team arrived, I provided a concise update on the fluid response. The patient was quickly stabilized and transferred back to the operating theater to control an active mesenteric bleed. By recognizing the early signs of deterioration, calculating the warning score accurately, and escalating using a structured communication framework, we prevented complete cardiovascular collapse and save the patient's life.
How do you ensure you obtain valid informed consent before a procedure?
Ensuring valid informed consent means verifying that a patient has the mental capacity to decide, acts voluntarily, and fully understands the procedure, risks, and alternatives. While the surgeon legally obtains consent, my role as a surgical nurse is to verify its validity during the preoperative check before the patient goes to theater. Last month, I prepped a 60-year-old male for an urgent hernia repair. His consent form was already signed, but during my final checklist, I asked him to explain what he understood about the operation. He grew anxious and admitted he signed it quickly because the clinic was busy, but he did not actually understand what the potential complications meant. I immediately paused the surgical pathway. I reassured him that consent is a continuous process and he had the absolute right to halt the procedure. I called the surgical registrar back to the bedside to re-explain the risks using clear, simple English. I stood by the patient, ensuring his questions about recovery timelines were fully answered. Only when he comfortably repeated the risks back to us in his own words did I confirm his consent was valid. This clinical vigilance protected the patient's legal rights and reduced his preoperative anxiety completely.
How do you prioritize your workload when you have multiple sick patients?
When managing a heavy workload with multiple acutely ill patients, I prioritize strictly based on clinical urgency, safety risks, and the ABCD framework: airway, breathing, circulation, disability, exposure. My approach relies on rapid objective assessment and dynamic reevaluation rather than managing tasks in chronological order. Last month, I was assigned a caseload of 4 post-operative patients when 2 began to deteriorate simultaneously. One patient, 2 hours post-appendectomy, developed sudden shortness of breath and an oxygen saturation drop to 88%. The second patient, who was post-cholecystectomy, had a sudden spike in pain scoring 8 out of 10, while a third patient required routine intravenous antibiotics that were due. The primary challenge was managing the immediate respiratory emergency while ensuring the other patients remained safe and did not feel abandoned. I applied the ABCD framework and prioritized the respiratory patient first, as a breathing compromise is immediately life-threatening. I administered high-flow oxygen, raised the bed head, and calculated a high NEWS2 score. Simultaneously, I recognized I could not be in 2 places at once. I immediately delegated the task of assessing the pain of the second patient to a qualified colleague and asked a healthcare assistant to check the vitals of the remaining stable patients. I then escalated the respiratory patient to the medical team using the SBAR tool. By stabilizing the acute respiratory issue within 15 minutes while leveraging my team to cover pain management and routine tasks, I ensured all patients received safe, timely care without any compromise to clinical standards.
How do you ensure your documentation is accurate and meets professional standards?
To ensure my documentation meets the strict standards of the Nursing and Midwifery Council, I treat record-keeping as an integral part of clinical care, not an afterthought. I strictly follow the core principles of contemporaneous documentation, meaning I write my notes as close to the time of the actual event or intervention as possible. This prevents the loss of critical clinical details that can occur at the end of a busy 12-hour shift. During a high-pressure trauma shift last month, I was managing a patient with multiple fractures who required frequent, complex interventions. The main challenge was keeping an accurate account of fluid balance, serial wound assessments, and frequent narcotic administrations while simultaneously coordinating with the orthopedic team. To maintain absolute accuracy, I kept a structured pocket notepad to log the exact timings of interventions, fluid volumes, and physiological responses immediately at the bedside. I then transferred these precise timestamps into the hospital's electronic health record system within 30 minutes of each major event. I ensured every entry was objective, clear, and entirely free of jargon, speculation, or personal opinion. I explicitly documented what I observed, what actions I took, and how the patient responded. By maintaining this disciplined, chronological approach, my documentation provided a seamless, legally robust narrative that ensured continuity of care for the incoming team and fully upheld the NMC Code of Conduct.
You are responsible for assessing, planning, implementing, and evaluating patient care. Walk me through your process for admitting a new surgical patient.
Admitting a new surgical patient requires a structured approach to ensure safety, accuracy, and full preparation before the first incision is made. My process follows the 4 distinct phases of the nursing process: assessment, planning, implementation, and evaluation, all completed within a strict timeline before the scheduled surgery. During the assessment phase, I greet the patient and verify their identity using 3 distinct identifiers: full name, date of birth, and unique hospital number, cross-checking these details against their identification wristband. I then conduct a comprehensive clinical assessment, measuring baseline vital signs to calculate an initial national early warning score. I review their medical history, explicitly looking for allergies, current medications, and past surgical complications. Last week, while admitting an elderly patient for an elective joint replacement, my assessment revealed she had taken her regular aspirin that morning despite pre-op instructions to hold it. This finding moved me immediately into the planning and implementation phases. I paused the standard pathway and immediately updated the surgical plan. I documented the medication gap and escalated the information to both the surgeon and the anesthetist using the SBR framework to evaluate the bleeding risk. Simultaneously, I implemented standard safety measures, including verifying valid informed consent, confirming the surgical site was correctly marked by the surgeon, and ensuring the patient had been fasting for the required time. In the final evaluation phase, I review the entire pre-operative checklist to ensure all loose ends are secured. This includes confirming that recent blood test results, such as group and screen, are logged in the chart and that the patient is wearing appropriate surgical attire and compression stockings. Once I evaluate that all safety criteria are met and the patient is emotionally reassured, I hand over the complete file to the theater team. This systematic process guarantees that the patient enters the operating suite fully optimized and safe.
The ward handles patients with complex needs, including those needing rehabilitation and medical intervention. How do you plan for a safe discharge with the MDT?
Planning a safe discharge for patients with complex needs requires early, proactive collaboration with the multidisciplinary team to prevent readmissions and ensure continuity of care. My approach is to initiate discharge planning at the point of admission, rather than waiting until the patient is medically fit, as complex social and rehabilitation setups take time to coordinate. Last month, I managed the discharge planning for a 78-year-old patient who had undergone an emergency laparotomy. She had complex needs, including reduced mobility, newly managed type 2 diabetes, and lived completely alone in a 2-story house. The primary challenge was ensuring she could safely manage her activities of daily living and insulin regimen without the risk of falls or severe medication errors at home. To tackle this, I organized an MDT discharge huddle involving the surgical registrar, an occupational therapist, a physiotherapist, a community nurse coordinator, and the patient's daughter. The physiotherapist evaluated her mobility and recommended a walking frame, while the occupational therapist conducted a home environment assessment, arranging for a bed to be set up on the ground floor and handrails to be installed in the bathroom. My role focused on coordinating the medical interventions and education. I spent 30 minutes each day teaching the patient and her daughter how to safely administer insulin and monitor blood glucose levels. I also collaborated with the hospital pharmacist to prepare a clear, simplified medication passport and arrange for the community nursing team to visit her daily, starting the morning after discharge. By utilizing the unique expertise of each MDT member and actively involving the family, we successfully discharged the patient on day 12. She remains safe at home with 0 complications or readmissions during her 6-week post-operative follow-up period.
The role requires you to administer medication in line with the Medicines Act and Misuse of Drugs Act. Can you tell me about a time you had to administer a controlled drug and how you ensured safety?
During a busy morning shift last week, I had to administer an intravenous infusion of morphine to a post-operative patient experiencing severe breakthrough pain. The primary challenge was executing this safely under intense time pressure while adhering strictly to the legal frameworks of the Medicines Act and the Misuse of Drugs Act. To ensure absolute safety, I initiated our hospital's mandatory dual verification protocol. I requested a senior staff nurse to act as my independent second checker. Together, we walked to the controlled drugs cupboard, which was securely locked as legally required. We jointly verified the stock balance in the controlled drugs register, ensuring the previous entries matched the physical vials. We checked the patient's electronic prescription chart against 7 specific rights: the right patient, right drug, right dose, right route, right time, right documentation, and the right to refuse. We carefully calculated the dosage, checked the expiry date on the ampoule, and drew up the medication together at the CD counter. Both of us signed the register to maintain a clear legal audit trail before leaving the clinical room. At the bedside, we verified the patient's identity using 3 distinct identifiers on his ID band. I administered the morphine slowly while my colleague witnessed the injection. I then monitored the patient's respiratory rate and sedation scores every 15 minutes for the first hour. The patient's pain reduced from 9 to 2 out of 10, with no adverse respiratory depression, fully demonstrating that strict legal compliance guarantees patient safety.
What is your understanding of infection prevention and control, IPC, in a surgical setting?
Infection prevention and control in a surgical setting is a critical safety framework designed to eliminate healthcare-associated infections and protect vulnerable patients from surgical site complications. In an environment where deep tissue is exposed, IPC dictates every aspect of the clinical workflow, requiring strict adherence to both standard and transmission-based precautions. My understanding is grounded in the absolute necessity of maintaining the chain of sterility. This begins before the operation with proper preoperative patient skin preparation and the strict enforcement of surgical hand scrubbing protocols. Within the operating theater, IPC requires continuous environmental monitoring, including checking laminar airflow systems, regulating room temperature, and restricting unnecessary foot traffic to keep airborne contaminants to a minimum. It also demands the meticulous inspection of every sterile instrument tray for moisture or indicator changes before use. As a surgical nurse, I treat IPC as a personal accountability. I am fully trained in aseptic non-touch technique for handling wound dressings and invasive lines on the ward. Furthermore, I recognize that IPC involves robust post-operative surveillance, which includes monitoring surgical wounds for early signs of erythema or exudate, and practicing disciplined hand hygiene between every patient contact. By treating IPC as a non-negotiable standard, we directly reduce patient length of stay and prevent life-threatening post-operative sepsis.
Describe a time you worked effectively as part of a multidisciplinary team. What was your role?
During a morning shift last month, our surgical team prepared for a complex, 4-hour pelvic exenteration involving a 60-year-old patient. The multidisciplinary team consisted of 9 professionals, including colorectal surgeons, a urologist, an anesthetist, a stomach-care nurse, a scrub nurse, and myself acting as the primary circulating nurse. The primary challenge was the logistical complexity of coordinating distinct surgical phases and managing specialized equipment changes between the different specialties without increasing the patient's time under anesthesia. My role was to serve as the central communication hub and coordinator within the theater. Before the first incision, I led the team through the formal WHO surgical safety checklist, ensuring all 3 surgical specialties were fully aligned on the procedural plan, expected blood loss, and antibiotic timings. Mid-procedure, the colorectal team encountered extensive adhesions that required an unexpected transition to specialized vascular staplers. Recognizing the potential for delay, I immediately coordinated with the Central Sterile Supply Department to retrieve the specific stapling devices within 3 minutes. Simultaneously, I updated the anesthetist on the progress so they could adjust fluid maintenance precisely. Thanks to this seamless MDT collaboration, we completed the complex procedure 20 minutes ahead of schedule, with 0 sterility or equipment hitches, ensuring the patient was transferred to the recovery unit in a highly stable condition.
Tell me about a time there was a conflict or disagreement with a colleague. How did you resolve it?
During an intensive orthopedic surgery last month, a senior scrub nurse insisted on using an instrument tray that had a slightly torn outer wrap, claiming the inner instruments were perfectly safe and that replacing the tray would delay the timeline by 15 minutes. As the circulating nurse, my immediate challenge was resolving this disagreement without escalating tension in front of the 6-person surgical team, while absolutely protecting the patient from an unsterile field. I knew I had to prioritize patient safety while remaining respectful of my colleagues' seniority. I requested a brief, quiet discussion away from the immediate sterile field. I calmly but firmly stated that according to our strict infection control guidelines, any compromise to the outer packaging meant the entire tray had to be treated as unsterile. I emphasized that our shared priority was preventing a surgical site infection for the patient. To resolve the issue quickly, I took immediate action by calling the sterile supply department and arranging for a runner to bring a fresh, identical backup tray up to the theater immediately. The new tray arrived within 4 minutes. My colleague acknowledged the risk, thanked me for handling the replacement so quickly, and we proceeded with the surgery safely.
In your role, you will need to liaise with physiotherapists, occupational therapists, social services, and consultants. How do you ensure effective communication with these different professionals?
Ensuring effective communication across a diverse multidisciplinary team requires a structured, objective approach that respects each professional's specialized role while keeping the patient at the absolute center of care. Because consultants, therapists, and social workers operate on different schedules and focus on distinct aspects of recovery, I adapt my communication style to match the specific context of the interaction. When communicating with consultants, my focus is on clinical precision and brevity. I rely strictly on the SBAR framework to present clear, objective facts, such as a precise national early warning score or a sudden change in post-operative fluid output. This ensures that busy medical staff receive the exact data they need to make rapid clinical decisions without any distracting fluff. For physiotherapists and occupational therapists, the communication becomes highly collaborative and focused on functional recovery timelines. I actively participate in daily morning board rounds where we discuss mobility milestones and discharge barriers. If a physiotherapist notes that an orthopedic patient requires specific weight-bearing assistance, I ensure that information is immediately updated on the nursing care plan so the ward staff can maintain that exact mobility protocol throughout the shift. When dealing with social services, the communication shifts toward long-term safety, funding, and community care packages. These professionals require detailed accounts of a patient's baseline cognitive and physical capabilities rather than just raw medical metrics. I provide them with comprehensive nursing assessments that highlight what the patient can safely achieve independently. By utilizing these distinct communication pathways and documenting every interaction clearly in the shared electronic health record, I ensure that our joint efforts create a seamless, safe journey for the patient from admission to final discharge.
The job involves taking charge of the ward in the absence of the senior nurse/in charge. What would be your priorities if you were the most senior nurse on the floor?
Taking charge of the ward requires a swift transition from individual patient care to overseeing global safety, team coordination, and bed management. On a hectic night shift last month, the ward manager was called away to an emergency meeting, leaving me as the most senior nurse on a 30-bed surgical unit. The immediate challenge was managing 2 unexpected emergency admissions from the emergency department while 3 existing post-operative patients were continuously buzzing for high-level pain management. My first priority was to conduct a rapid 10-minute huddle with the 4 staff nurses and 2 healthcare assistants on duty to reassess the acuity of the entire floor. I reallocated our staff resources dynamically, pairing a junior nurse with an experienced colleague to handle the incoming emergency admissions safely. I then designated myself as the free-floating coordinator to oversee complex clinical escalations and manage the ward's overall throughput. I maintained direct contact with the bed management team and the surgical registrar to ensure our discharge pipelines remained clear. By maintaining high visibility on the floor and leading with calm authority, we safely admitted both emergency patients and controlled the ward's pain management demands within an hour, maintaining absolute clinical safety without any adverse incidents.
Can you give an example of a time you used evidence-based practice to change or improve patient care?
Using evidence-based practice is essential to improve clinical outcomes and ensure nursing care aligns with the latest research. Last winter, I noticed our surgical ward had a high rate of post-operative urinary tract infections, with 4 cases recorded in a single month. The main challenge was that staff were routinely keeping urinary catheters in place for 48 hours post-surgery simply out of habit, which contradicted current national guidelines. I conducted a literature review and found strong evidence showing that removing catheters within 24 hours reduces infection risks by 50%. I presented these findings to our ward manager and the surgical consultants during our weekly meeting. Together, we implemented a new daily catheter review checklist on our electronic health record system, forcing clinicians to justify keeping a catheter in place every morning. I then spent 2 weeks educating the nursing team on early removal strategies and alternative mobility plans. Over the next 3 months, our compliance with the 24-hour removal guideline rose to 95%. Most importantly, post-operative urinary tract infections on our ward dropped from 4 cases a month to 0. This change proved how integrating fresh research into daily routines directly protects patient health.
The job requires you to participate in clinical audit. What is your understanding of clinical audit and its importance in nursing?
Clinical audit is a structured, quality improvement process that evaluates current nursing practice against established, evidence-based standards. The main challenge in a busy surgical environment is overcoming the perception that audits are merely bureaucratic exercises, transforming them instead into meaningful tools that directly eliminate clinical variations and improve patient safety. Last year, I participated in a clinical audit focused on our ward's compliance with the WHO's surgical safety checklist. I reviewed 20 patient charts over a 2-week period, specifically looking at whether the timeout section was fully completed before bedside chest drain insertions. The audit revealed a 20% gap in documentation, which highlighted a significant risk of wrong side errors. Following this finding, I worked with the clinical nurse specialist to design and implement bright, highly visible reminder posters next to all procedure trolleys. We also introduced a brief, mandatory 2-minute huddle before any invasive bedside procedure. A re-audit conducted 3 months later showed that our compliance rate surged to 98%. This experience demonstrated that clinical audits are vital because they provide objective data, foster accountability, and drive the continuous refinements needed to protect vulnerable post-operative patients from avoidable harm.
How do you maintain your professional development and keep your clinical skills up to date, especially concerning the NMC Code of Conduct?
Maintaining my professional development requires a proactive commitment to lifelong learning, ensuring my practice aligns with the latest clinical evidence and the Nursing and Midwifery Council guidelines. The main challenge in an acute surgical environment is finding time to engage in meaningful reflection and training amid the fast-paced demands of a 30-bed unit. To stay current, I dedicate 2 hours each week to exploring the Royal College of Nursing resources and the British Journal of Surgery. This regular reading helped me implement an updated, evidence-based protocol for managing deep vein thrombosis on our ward last autumn. Additionally, I maintain a detailed professional portfolio where I document my participatory learning hours and write structured reflections on complex clinical scenarios I encounter. Whenever the NMC updates its code of conduct, I actively cross-reference my daily practice against the core themes of promoting professionalism and trust. Last month, I completed a certified advanced airway management course to enhance my post-operative rescue skills. I shared these new insights with my colleagues during a 15-minute teaching session at our morning huddle. This disciplined approach to continuous education ensures my clinical skills remain sharp, legally robust, and fully capable of delivering high-quality, safe patient care.
What is your role in safeguarding adults and children?
Safeguarding adults and children involves recognizing vulnerability, identifying abuse indicators, and taking immediate action to protect individuals from harm. On our acute surgical ward last winter, I cared for a 10-year-old child admitted for an emergency appendectomy who was accompanied by an aggressive guardian. The main challenge was that the child appeared unusually withdrawn, fearful, and had unexplained bruising on his upper arms that did not align with the surgical presentation. I prioritized the child's safety by creating a secure environment to assess him without the guardian present. I utilized the opportunity during a routine post-operative wound check in the treatment room to ask gentle, open-ended questions. I carefully documented the specific size, shape, and color of the bruising in the electronic medical notes using objective, non-judgmental language. I immediately escalated my concerns to the hospital's dedicated safeguarding lead and filed a formal child protection referral within 2 hours of my observation. I also briefed the nurse in charge and the attending consultant to ensure the guardian was monitored while on the unit. Social services intervened that same evening, launching a coordinated safety investigation. By maintaining high vigilance and following strict legal protocols, I ensured the child was protected from ongoing harm.
What are the principles of the NMC Code of Conduct? How do you apply them in your daily practice?
The Nursing and Midwifery Council Code centers on 4 core principles: prioritizing people, practicing effectively, preserving safety, and promoting professionalism and trust. I embed these standards into my daily surgical nursing routine to guide every clinical decision. To prioritize people, I always advocate for my patient's autonomy. For example, last week, I delayed a scheduled inguinal hernia repair because the patient expressed deep confusion about the surgical risks, ensuring the consultant returned to re-explain the consent form. I practice effectively by keeping my clinical skills current, such as attending recent training on negative pressure wound therapy to manage complex abdominal incisions with evidence-based techniques. Preserving safety means speaking up instantly when risks arise. During a hectic shift yesterday, I challenged an incorrect medication dose on an electronic chart before administration, preventing a potential drug error. Finally, I promote professionalism and trust by maintaining absolute honesty and documentation integrity, especially during high-stress handovers. By upholding these 4 pillars, I protect my patients and maintain the integrity of the nursing profession.
Tell me about a time you made a mistake. What happened and what did you learn from it?
Admitting and learning from errors is essential for ensuring long-term patient safety and professional growth. 2 years ago, during a busy evening shift on an acute surgical ward, I was preparing intravenous antibiotics for a post-operative patient. The main challenge was that the ward was experiencing a high volume of admissions, and I allowed myself to be interrupted by a colleague mid-calculation. Due to this distraction, I reconstituted the medication with the incorrect volume of diluent. Fortunately, my hospital mandates a strict independent double-check for all intravenous drugs. Before administration, I asked a senior nurse to verify the medication. She immediately noticed the calculation error during her check, preventing the incorrect dose from reaching the patient. I immediately discarded the ruined medication, logged the near-miss incident on our electronic reporting system, and completed the task correctly. This mistake taught me the vital importance of cognitive focus during medication preparation. I learned to practice the sterile cockpit principle, politely refusing interruptions while handling drugs. Since that incident, I always utilize a dedicated medication preparation zone and have maintained a flawless safety record, proving that a near miss can successfully transform daily clinical habits.
The environment involves frequent exposure to highly unpleasant working conditions and potentially verbal aggression. How would you de-escalate a situation with an aggressive patient or visitor?
De-escalating aggression in a high-pressure surgical ward requires emotional control, active listening, and a structured approach to personal safety. Last month, a patient's relative became verbally aggressive at the nursing station, shouting and slamming his fists because his father's theater time was delayed by 2 hours due to an emergency case. The main challenge was containing his public outburst quickly to prevent distress to other patients while ensuring the physical safety of the ward staff. I immediately stepped out from behind the desk, maintaining a safe 2-meter distance and an open, non-threatening posture with my hands visible. I spoke in a calm, low, and deliberate tone, deliberately slowing down my speech to avoid matching his high energy. I invited him into a quiet, private side room away from the main corridor, removing his audience and lowering the immediate tension. Inside the room, I listened without interrupting for 2 full minutes, validating his frustration by acknowledging that waiting for surgery is incredibly stressful. Once he calmed down, I clearly explained the medical urgency of the emergency case without using complex jargon. By demonstrating genuine empathy while setting firm boundaries regarding respectful behavior, I successfully defused his anger. He apologized for his outburst, and we agreed on an updated communication plan for his father's procedure.
How do you maintain compassion and person-centered care when you are working under immense pressure in a busy surgical unit?
Maintaining compassion and person-centered care under pressure requires conscious prioritization, active listening during routine tasks, and treating each patient as an individual rather than a medical condition. Last winter, our surgical unit faced a severe beds crisis, requiring us to manage 5 complex post-operative admissions simultaneously. The main challenge was ensuring that a frightened, 80-year-old lady awaiting an urgent mastectomy felt seen and cared for, despite the chaotic environment around her. I realized that even when time is limited, the quality of a connection is defined by presence. During my initial 3-minute clinical assessment at her bedside, I made a conscious effort to sit down at her eye level, make direct eye contact, and use her preferred name. I actively listened to her fears about the upcoming surgery without checking my watch or looking at the computer screen. I clustered her clinical observations with simple comfort measures, such as adjusting her pillows and bringing her a warm blanket, ensuring she felt physically supported. By integrating human warmth into necessary clinical tasks, I provided high-quality, person-centered care without delaying the ward's workflow. The patient later expressed how safe and comforted she felt during a terrifying moment, proving that true empathy takes seconds, not hours.